Everyone, welcome to this week's Health for the World Radiology Grand Rounds. Please feel free to introduce yourself and tell us where you're logging in from. It is my pleasure to introduce our guest speaker for this week, Dr. Elliot Koo. Dr. Koo will be giving a talk on blunt bowel and mesenteric injury. Dr. Koo is an assistant professor of radiology at University of New Mexico School of Medicine, and he's an emergency radiologist there. Um, and without further ado, Dr. Koo, please take it away.
All right, thank you for the introduction, Dr. Patel. So I enjoy lecturing on this topic of blunt bowel and mesenteric injury because it's pretty challenging. But I think that with a little bit of guidance and practice, it can become less daunting. And it's a challenging topic for a variety of reasons. For one thing, blunt bowel injuries are relatively rare. Um, they're reportedly present in only about 1 to 5% of blunt abdominal traumas. And they can be difficult to diagnose clinically. For one thing, the symptoms could be rather nonspecific. And as well, in the setting, in a polytrauma case, there can be a lot of distracting injuries. And then as well, a lot of these trauma patients come in altered, intoxicated, or otherwise unconscious, which can further make things difficult to make a diagnosis. And then lastly, it can be a difficult imaging diagnosis. In general, CT is not always that great for bowel, especially small bowel. And the findings on CT can be rather subtle, especially when you have multiple concurrent injuries, such as other solid organ injuries. But it's certainly an important diagnosis to make because a missed or delayed diagnosis can lead to increased morbidity and mortality. Motor vehicle collisions are by far the most common cause of blunt bowel injuries. And there are three mechanisms of injury that have been described in the literature. I'm providing this discussion briefly, really just to provide you with a frame of reference and kind of help you, piece together, the mechanisms of these injuries in your mind. But this is certainly not something that, this isn't level of detail that you would put in a radiology report, for example. So the first one is a shear type injury, which typically occurs at locations where the bowel is fixed, such as the ligament of Treitz, ileocecal valve, and the sigmoid colon, for example. And it basically is a rapid deceleration injury that can cause a laceration of the bowel and or mesentery. And this can lead to vascular disruption, which can then subsequently lead to small bowel ischemia. And I have a couple examples to show you of that later on. The second mechanism is a crush type injury, which is essentially a compression between an external force, such as a seatbelt, a dashboard or a steering wheel against, the skeleton. And then the last one is, I think, probably the least common, but is, this burst type mechanism, which is a perforation secondary to increased intraluminal pressure. So this would happen in the case of someone who has like a pre-existing small bowel obstruction or an ileus or, Crohn's disease or something like that. And again, these mechanisms that I'm describing are just kind of more of an academic discussion and don't actually need to go into the radiology report. Just a quick note on oral contrast use. A meta-analysis of 32 studies showed that there is no significant difference in accuracy of CT performed with oral contrast versus CT performed without oral contrast for detection of blunt bowel and mesenteric injury. Doing a CT without oral contrast has a high sensitivity and specificity, as shown here. And so the take-home point is that oral contrast is not necessary for detecting blunt bowel injuries. And this is a good thing because if you are in a busy trauma center like ours here at University of New Mexico, there would be quite a big time suck if you're giving every patient oral contrast, and there would be a delay in care for a lot of those trauma patients. So I have a pretty simple approach to detecting blunt bowel injury. And if there's one slide that you remember from this lecture going forward, I would say this is it. I divide things into direct or indirect signs. Some of these signs are categorized differently depending on what study you read. So I would advise you not to get too hung up on the terminology here. Ultimately, this is based on the specificity of these signs. So anything that's, in the literature reported as about 90% specific or higher, I personally refer to as direct signs. And then the ones that are relatively non-specific are the indirect signs. So direct signs include bowel wall discontinuity, free air, focal bowel wall thickening, and focal abnormal bowel wall enhancement. Indirect signs would be free fluid and mesenteric stranding in fluid. A note on that, I'm going to talk about mesenteric injuries towards the end of the lecture. But a mesenteric injury in and of itself is an indirect sign of a blunt bowel injury. So in other words, you can have a mesenteric injury with or without a concurrent blunt bowel injury. And I'm going to go into each of these in a little bit more detail here before we get to some cases. So with direct signs, bowel wall discontinuity is 100% specific, obviously. But you are typically not going to see this, or at least it would be very difficult to call this prospectively, especially without oral contrast on board, which for reasons I just discussed, we typically don't do. So you'd rarely be able to, you'll rarely see this outside of textbooks, and if you're ever able to call it, it'll probably be in a retrospective manner. The next one is free air, which is 95% specific, but note not pathognomonic for bowel injury, because you can have other sources such as pneumothorax or chest tube placement or diaphragm injury. Reportedly, it's seen in a range like 30 to 60% of cases. But if you see it in combination with free fluid, seatbelt sign, body wall contusion pattern, or a focal bowel abnormality, it's highly predictive of a blunt bowel injury. And I should mention, it's important to note the location of extraluminal air. For instance, certainly you can see intraperitoneal air, but sometimes if the location of the bowel is in the retroperitoneum, such as in the second through fourth portions of the duodenum, the ascending or descending portions of the colon, then you may have an injury of those as well. And you may see little locules of gas in the retroperitoneum. I would say, at least anecdotally in my experience, a tip would be to look for small locules of gas immediately adjacent focal bowel abnormality, and I think that can be helpful for cluing you into where there's an abnormality. All right, moving on with direct signs, focal bowel wall thickening. This measurement that's provided is in literature, but I never actually measure the bowel. I kind of just, I gestalt it. If it looks focally thickened, and typically these are focal, short segment, rather than diffuse when you have an injury. And this is a pretty specific sign, which is why I include it in the direct signs. The other one is abnormal bowel wall enhancement. And by that, I mean hyper or hypo enhancement, or both in the case of this thing called the Janus sign, which I'm showing here. Janus is a two-faced Roman god, which is where it got the name, because you can have basically the idea is that you have adjacent loop of bowel where one portion of it is hypo enhancing and one portion is hyper enhancing. And basically the mechanism for the hypo enhancement is mesenteric vascular disruption leading to ischemia. And then hyper enhancement is due to increased vascular permeability from hypoperfusion. So most of the cases I've seen, at least, if I've seen it at all, it's usually hyper enhancement, but certainly you can have either or, and those are signs. If you see that with focal bowel wall thickening, it's pretty suspicious. Moving on to indirect signs. So free fluid, certainly it's the most sensitive sign for what it's worth. But it's not very specific, because you can have free fluid from, or hemorrhage from, concurrent solid organ injuries, for example. It's important to note that, and you've probably all seen this a lot, there could be small volume physiologic pelvic free fluid in typically premenopausal females. And also in reported 3% of male trauma patients, there may be a small amount of pelvic free fluid in the absence of any other injury. It can be hard to determine what to do with these findings. If I come across this, then I will typically, in the impression, just mention that there's a small amount of, or there's a trace amount of nonspecific pelvic free fluid without any other, abdominal pelvic injury identified. And that kind of just volleys it back to the trauma team to figure out what to do with. If you don't see any other injury, it's kind of, that's kind of where you have to go with that, I think. So that's just the caveat to the free fluid. And then the other indirect sign is mesenteric stranding. So this would suggest that there's mesenteric contusion, or you may have hemorrhage or mesenteric hematoma, for instance. As I mentioned, you can have these with or without bowel injury, but in and of itself, it is an indirect sign that you might have a bowel injury as well. And then when you have mesenteric stranding, it's important then to look very closely for extravasation of IV contrast material, because if there is active bleeding in the mesentery, as I mentioned, if you have some sort of vascular injury in the mesentery, this can lead to ischemia. So they may, take this patient to surgery anyhow. So, sorry, I had a lot of wordy slides, but now I'm just going to go to a bunch of cases. These are all cases from the University of New Mexico, and we have definitely high throughput in our emergency department. A lot of really intense traumas, so we've luckily been able to collect a lot of cases of bowel injury, even though it's pretty rare. So for these cases, the red arrows are going to indicate direct signs of bowel injury, blunt bowel injury, and the yellow signs are going to indicate indirect signs. So this first one is a motor vehicle collision. And as you can see here, this is, sorry, this is kind of a zoomed in image to show, the findings better, but it's a coronal CT reformat. So here you have a focal loop of jejunum that's demonstrating abnormal wall thickening. So that's a direct sign. There is this locule of free air immediately adjacent to it, which is certainly concerning. And then, on retrospective review of it, I think this linear lucency that this linear hypodensity that basically leads to this locule of air is probably laceration or bowel wall discontinuity, which again, this wasn't called prospectively, but looking back on it, this is probably what that is. And then you have indirect signs of a little bit of free fluid / hemorrhage layering here, and this mesenteric contusion as well. So the way I reported this when I came across this case, because there are all these signs kind of all together pointing towards a bowel injury, I described it as, the findings are highly suspicious for, jejunal injury in this location. Here's another case of a motor vehicle collision. Notice that there is a little bit of free air in the retroperitoneal space adjacent the ascending colon. So we have, and then we also have a little bit of focal colonic wall thickening here. So there's two direct signs, plus we have a little bit of free fluid / hemorrhage, and there was an ascending colon injury in this case. Here's another example of yet another motor vehicle collision. As I said, this is the most common cause of these types of injuries. And here, so this is the descending colon, and then here's a loop of jejunum, which, as you can see, is focally pretty thickened. The wall is pretty thickened. There are these subtle locules of free air immediately adjacent to it, and then there's this mesenteric stranding as an indirect sign. Now, sometimes I advise the trainees, when there's little tiny locules of gas like this that you could easily scroll past because it kind of very closely blends in with the adjacent intraperitoneal fat, it can help to put the image in a lung window and then invert the image. And sometimes that helps make little locules of free air pop out more. So in this case, there was indeed a jejunal laceration when they took the patient to surgery. Here are two different examples. The one on the left is a motorcycle collision, and the one on the right is a motor vehicle collision. These are probably, it's kind of hard it's hard, but these are probably the best examples I have of focal bowel wall hyperenhancement. And they're fairly subtle in this case, but there's a little bit of wall enhancement here in the distal ileum, with perhaps a little bit of hemorrhage here and some mesenteric contusion here. And then in this case on the right, you have a little bit of very subtle focal bowel wall thickening and enhancement immediately adjacent hematoma slash hemorrhage. And both of these were cases of small bowel perforation and or injury. And in these cases, notice that there are body wall contusions, on the same side of the injuries. I think that kind of helps kind of clue you in to where there could be a potential injury, is looking at the body wall contusion pattern as well. And this was a kiddo who had a bicycle handlebar to the abdomen. And in this case, you'll notice that there is quite a bit of free fluid interspersed throughout bowel loops. So we have indirect sign with the yellow arrow of the free fluid. And then the red arrows are pointing at locules of free air, as well as multifocal areas of jejunal wall thickening. In this case, it can be a little bit more difficult because typically the bowel injuries are focal and don't have a diffuse appearance. In this case, it could almost fool you into thinking there's diffuse thickening. But actually what happened is this patient had multiple jejunal lacerations, which was causing this appearance. And I think, the presence of free air, all these locules of free air, is certainly suspicious, and in combination with these findings is going to push you to, be very concerned about a bowel injury in this case. So I think you're starting to probably see the pattern here. Another MBC, and again, indirect signs of mesenteric contusion, free fluid, direct signs of focal small bowel wall thickening. Possibly there's discontinuity right here, but again, this is more, of a retrospective finding. And a quick note on potential mimics. So I mentioned diffuse, with blunt bowel injuries, it's typically not a diffuse finding. You can have, for instance, with shock bowel, diffuse bowel wall thickening and mucosal enhancement due to systemic hypoperfusion. There's also, of course, ancillary findings that you're going to see, such as, in this case, you can see flattened IVC, small caliber intra-abdominal, infrarenal abdominal aorta, and other things like adrenal gland hyperenhancement. But again, this is more of a diffuse process. There's this other thing called jejunal pseudothickening. This was in a kid who did sustain trauma, and they had a liver lac, and their jejunum was kind of diffusely, had this diffusely sort of thickened appearance. But again, this was more of a pseudo thickening appearance, just the bowel being decompressed rather than injured. And this can be kind of tough to differentiate from a multifocal injury like the one I just showed you. But the case that I showed you previously, there were other secondary signs such as free air, hemorrhage, mesenteric stranding, things like that, that helped indicate that there was bowel injury rather than just a mimic. Okay, so moving on to mesenteric injuries, I just keep it simple and divide it into, contusion, hemorrhage, and or hematoma, and then active bleeding. So I have a handful of cases to illustrate this. Here are some mesenteric contusions in a blunt injury. Here's maybe a little bit of hemorrhage / contusion here. And the way I would report this one, if there are no other direct signs of bowel injury, I would say, multifocal mesenteric contusions without direct evidence of bowel injury. Here is another case of a very small mesenteric contusion in the central mesentery. This was actually a case I had recently, I think last week or the week before, and there was no evidence of bowel injury. I happened to see a follow-up in this patient because the patient was doing poorly clinically, so they ended up taking them to the OR, and they did not find a bowel injury intraoperatively, just a small mesenteric contusion. Here's more of an example of mesenteric hemorrhage. It's helpful to look for these little triangles of fluid in the mesentery. And again, this was another case where there wasn't convincing evidence of bowel injury, but there was some mesenteric hemorrhage, and it was reported as such. And here we have mesenteric contusion with a little hematoma, which is immediately adjacent a loop of distal ileum. There weren't direct signs of bowel injury in this case, but the radiologist who read it, raised concern for possible bowel injury. They did take this patient to surgery, and I believe they found a vascular injury, which resulted in a little bit of ischemia of the distal ileum. So they then subsequently resected it. Even looking back on the case, I was not able to see, hypoenhancement of the, distal ileal wall, for example. So that's where it becomes important when you're reporting things, to kind of just be descriptive and not come down too hard one way or the other. I think in this case, it was wise to raise concern for possible bowel injury, because then, even though we didn't see direct signs, there was still the issue of small bowel ischemia that needed to be addressed. Here's a good example, rather subtle on the axial, of active bleeding in the mesentery. So we have mesenteric contusions with these tiny foci of active extravasation, which actually pop out better on the coronal reformat. And this patient was taken to surgery, and they had a vascular injury that needed to be repaired. Oftentimes, in my experience reading these studies, when there is a vascular injury, they're often taken to surgery. So it's really important to look for that, those little foci of active bleeding. Here's another case of active bleeding within a mesenteric hematoma. So there's quite a bit of hemorrhage surrounding the loops of small bowel and in the mesentery. And again, you can see these little foci of active bleeding. This one's pretty severe. This was I think a guy who was hit by a pedestrian who was hit by a bus, and it sheared his inferior mesenteric vein. So you have all this mesenteric hemorrhage / hematoma, and active bleeding from the IMV, which you can see even more clearly on the coronal reformat. And then here's another case of pretty profound active bleeding. And as you can see, it's closely abutting a loop of ileum. So in this case, the radiologist reported, there's this, large amount of active bleeding coming from this mesenteric hematoma, and it was immediately adjacent a loop of small bowel, which raises concern for a bowel injury as well. And this was another one of those cases where when they opened the patient up, they found a vascular injury, of course, but there was also resultant small bowel ischemia. And in this case, you could potentially argue that maybe the wall here of the bowel is a little bit hypoenhancing, which is certainly concerning. But again, it can be, in the setting of polytraumas and, the different appearance, how the bowel can appear, this can be difficult to call prospectively. So just a few more things. Blunt bowel injuries are associated with chance fractures or flexion distraction spine injuries, and this may relate to that crush type mechanism that I described earlier. Multiple solid organ injuries. So the risk for a blunt bowel injury increases to roughly 30% when 3 solid organ injuries are also present. And also there are studies that have shown that there's increasing risk of blunt bowel injury as the number of solid organ injuries increases as well. And then pancreatic injuries are associated with a duodenal injury in approximately 20% of cases. And then the other thing is, seatbelt sign of body wall contusions, that's often has an association with bowel injury as well. Here's some references. I do have a couple more points I want to make. So I think reporting on bowel injuries, the way you report it is important to consider, because you certainly don't want to undercall something and miss it, but you also don't necessarily want to overcall something and force the surgeon's hand when there's no bowel injury present. So I never come down on things too hard. Basically, if I see a constellation of findings that are highly suspicious, I don't just say, there is a bowel injury, period. I just say, the findings are highly concerning for a bowel injury, in this location. If I'm a little bit less sure, like in that case of maybe there's, this big mesenteric contusion with active bleeding adjacent of small bowel loop, I can say, this raises suspicion or raises concern for a bowel injury. If I don't see a bowel injury, but I see, say a mesenteric contusion or something like that, or I don't see any signs of bowel injury, I just say no direct evidence of bowel injury in the findings, for instance. The last point I want to make is I typically, any case that I come across where I think there's a bowel injury, I always save it and refer back to it later to see if they took the patient to surgery. And if they did, I look at the operative report and compare that with the findings on the CT later on. I have found that has made me much better at detecting bowel injury than going forward. So I recommend that everyone do this to whatever capacity they can. I think it's a good habit in general for any potential surgical case is to look back. But especially, I think it'll make you better at detecting bowel injuries when they come to you. So sorry, this is a bit of a short lecture. I try to keep things as concise as possible because I think that usually like half-hour lectures are the easiest to retain information from. And really appreciate everyone's time. This is a picture of my kids from the other morning. If anyone has any questions, I'll be happy to try to answer them.
Thank you, Dr. Koo, for the lecture. We learned a lot on blunt bowel and mesenteric injury. We are getting a lot of messages in the chat box about, thank you, Dr. Koo, for the enlightening lecture, great presentation. We also have greetings from University of New Mexico.
Oh, sweet.
Dr. Barry Bacon, he says that thanks for the pictures of your kids. Very cute. Greetings from Washington State. Lots of compliments coming in. We do have a couple of questions. The first question is by Dr. Enrique Monero. He asks whether fast ultrasound is useful in diagnosing these pathologies.
That is a good question, especially for my emergency medicine colleagues, because at least at the University of New Mexico, the fast ultrasounds are performed by the emergency radiology doctor, or sorry, the emergency doctors, not the emergency radiology doctors. So I don't interpret those, but I think that they are at least a good initial scan to look for free fluid in the abdomen, which will then necessitate further imaging. Because like I said, the free fluid is rather nonspecific. You're going to see a lot of cases with significant liver or spleen injuries or kidney injuries, for example. So it's really like a screening tool to see, if there may be a significant injury in the abdomen. And then again, in our institution, all the major traumas, the ones that are stable are gonna go to the CT scanner. But at least I think in other institutions, for example, a fast scan is a good initial screening tool to look for just free fluid in the abdomen. And again, non-specific, could relate to a bowel injury, could relate to a solid organ injury. I hope that answers the question.
And it's easily available as well.
Yeah, for sure.
Where resources are sparse.
Mm-hmm.
We have another question. How do we differentiate between pseudo bowel wall thickening from true bowel wall thickening in setting of trauma?
So I think one would be a more diffuse. So the pseudo thickening is going to be a more diffuse process, where the small bowel is just diffusely kind of appears, the wall appears thickened, versus a blunt bowel injury is typically, except in that I did show you the one case where there were multiple jejunal lacerations, but typically it's going to be you're going to see a more focal bowel abnormality. In my experience, in the vast majority of the bowel injuries I've seen that actually panned out to being a true laceration of the bowel, it has been more of a focal abnormality. So you see a short segment of bowel wall thickening. The other thing is you really want to look for those other signs, those other direct and indirect signs. So if you see, hemorrhage immediately adjacent to that loop of bowel, or contusion immediately adjacent, like in the mesentery, or fat stranding, and then the other thing is like little locules of free air. I think then you really have to look at the whole picture. In most of the cases of bowel injury I've seen, almost all the cases of bowel injury I've seen, there are multiple signs present that you just have to slow down and look very carefully for. And it's not often just like a single sign. And so I think that's the best way to really tell the difference.
And we have one more question. What is your imaging protocol for rectal injury?
For rectal injury, so for that, typically it'll be I didn't talk about penetrating injuries in this lecture, but for the penetrating like injuries where they're worried about rectum, they'll do the CT with IV contrast, but they also generally administer rectal contrast to see if there is extravasation of contrast from the rectum.
And I think we have one more question here. So, is intraluminal contrast totally disregarded in the setting, or is that something we still use?
At least in our institution, we don't use it. Based on just the research that's shown, it doesn't increase the sensitivity or specificity of detection of specifically blunt bowel injury. So I can't speak to other institutions, but I think mostly in the major trauma centers in the United States, they don't. My understanding is that oral contrast is not used in the setting of detecting blunt bowel injury. Now, like I said in the last question, if there's concern for a penetrating injury, say in the rectum, then they'll administer rectal contrast, but that's a different sort of setting. I'm talking about specifically blunt bowel injury, and again, it's not adding oral contrast has not been shown to increase sensitivity and specificity for detecting those kinds of injuries.
That's good to know.
And
I
it
think
would certainly delay the time that the patient is, when you're giving oral contrast, you have to wait a while, especially if you're going to want it to transit through the small bowel. So that can certainly delay care in a patient who's sustained an injury severe enough to, get a small bowel injury or a bowel injury, because usually the patients that get bowel injuries have had pretty major trauma.
yeah, I think that's all for the questions. We do have some more messages that says thank you, great lecture. Thanks for the great lecture from University of Sao Paulo, Brazil. Um, I think that's it.
All right. Thank you for your time, everyone. Really appreciate it.
Thank you. And that concludes our grand rounds for this week. Thank you.
All right. Thank you.